Exploring movement, exploring our body.
Deviation of center.
Inside edge of the foot.
Just crushing you from here.
Different angles.
Like, these kids don't want to be here.
Heel into roll.
Perception is the engine that drives our entire experience.
On today's episode of the Performance Explorer Project, I have Dr. Jordan Shallow. We get into concepts of what is pain, assessing the hip and troubleshooting the shoulder, introducing sensory data to close the predicational gap with the brain, coming back from injury and using strength training to feed perceptual engine sensory data, and breaking the feedback loop of pain. Let's get into this episode. As founder and owner of Prescript, chiropractor of Apple's World Headquarters in California, strength and conditioning coach at Stanford University, private sector strength and conditioning rehab for athletes in the NFL, MLB, NHL, tennis, Olympics, now founding member of Spoken Nutrition. How did you get here?
Say yes and figure it out. I mean, yeah, dude, that was it. I mean, come out of school. I mean, environment is everything. Right? We talk about how does the external environment dictate the internal demand. So put yourself in good environment, put yourself in good situation. Went to grad school in California, and then just like those are the jobs that are there. Like you're in Silicon Valley, it's like, you know, I could have, if I went to Dubuque, Iowa, and went to school there, my first job may have been in Joe's Rack and Crack Chiropractic Clinic. That equivalent in Cupertino, California is Apple's World Headquarters, right? So like say yes, figure it out, say yes, figure it out. So that's been every one of those. It's just been a consequence of that.
I personally don't have, I don't think, a single client that is not in pain. I think that's why people come to me. It's to get out of pain, to feel better. But the way that you talk about pain, I just find it very fascinating. Tell me a little bit more.
What is pain, right? There's a lot of things. Classically, people will look at pain as an emotion, a sensation, and a drive state, right? That's sort of like the classic three. And these can fraction off in the tentacles of each one of those. It can get a little complex. But those three things I think are worthy of kind of exploring. It's like, it's an emotion. And we all kind of know what that is, right? If there's one thing that's universal, right? Like when you look at green and I look at green, I have no idea what your brain generates.
Yeah, what shade of green that is.
Right, yeah. And you know, like, exactly. Some people are like, oh, it's mauve. I'm like, that's purple, dude. I don't even know what mauve is. Miss me with the mauve stuff. But pain, I think, is something we all get, right? It's a primal error signal, right? It's data, it's information, it's a behavior change mechanism, right? So it's like there's a drive state component to it. It inspires some sort of change in behavior. You know, then there's the emotion piece, which I think was fairly universal. And this idea of pain being a sensation, which is like, this is where we run into the fun stuff. Pain and its universality in the experience of pain fits this cognitive framework that I could have alluded to earlier, which is like, if you don't think about it, your default, if you are to think about it, is and how we generate our conscious perception is that we think that we are taking in the world as it is. It's not at all the case. Right? Have you ever seen it's called the monkey business illusion? Or maybe this is a little bit more modern. The Facebook blue dress, gold dress.
I have.
Do you remember that? Okay, What did you see? Do you remember?
I think I remember seeing blue, if I'm being honest.
Yeah. So I was blue to the death.
Yeah.
I didn't even get what all the fuss was about.
I didn't understand it at all.
And then that's where the magic was. No one did. Because if you saw gold, you saw gold.
Yeah.
There was not a chance, like you thought the dude was fucking with you.
Yeah.
Like, what do you mean you see blue?
Yeah.
That was such a visceral moment in like a social experiment that really drew attention, because that kind of just went, oh, that's crazy. Wow. Think about that.
Yeah.
50% of the people saw completely, and it wasn't like mauve or purple. I think those are close, but like, it was a completely distinct, like, the LA Lakers are fucking purple and blue. It's like, no, they were gold and purple. You know what I mean? Like, that is not even close. How the fuck can you see that? It's like perception, right? So understanding how humans generate, one, the fact that they do generate their perception, that the way that our hardware of our brain works is it's this top down, it's building things, it's generating, it's predicting. Essentially, your brain makes bets. It makes bets on what your sensory perception is going to be. And then your sensory perception, or I shouldn't say sensory perception, your sensory input feeds and compares a predictive model, right? So when we look at pain, we can see pain as a sensation, and we'll talk a little bit about the sensory unit of pain, the nociceptor, right? The free nerve ending that sends the sensory data of pain to the brain. But then we look at, as a drive state, like it springs you to action. It's a behavior change mechanism. We see it as an emotion. Like those are kind of the three pillars. All of those pillars fall under the umbrella of pain as a perception. Now the question isn't what is pain, it's what is perception. How do we generate perception? Why is it that you saw fucking blue and someone else saw gold? How is that possible? How can they have two different perceptions of that dress? Right. So I'm going to bring up the monkey business one, because when I explain it, you may be familiar with it. It's a study. It's actually not directly linked, or its initial use case wasn't directly linked to this, but it really fits. There's 6 people. 3 are wearing black t-shirts, 3 are wearing white. Each team has a basketball. And the white team is passing the basketball.
You have seen. And the monkey's moving around.
Fucking monkey walks.
Yes.
Do you remember the first time you didn't see the monkey walk in?
I'm gonna be honest, I saw it immediately.
Okay, amazing. That may come down to your tactical background and your situational awareness. But for those kind of following along at home, the monkey business illusion has, a room maybe not much bigger than this, very tight quarters.
Yeah.
And you have, again, everyone's wearing blue jeans, white t-shirts, black t-shirts, 3 of each. The prompt at the beginning of the video is how many times does the white team pass the ball to each other? So what happens for most people, and this happened to me, I remember watching it in Psych 101, Professor Kramer, University of Windsor, where I started my undergrad, political science and history. And he puts it up, and dude, I was floored. I made him rewind. Like everyone was like, whoa, what do you mean? So essentially what happens is you're watching this video and it's maybe like 30 seconds.
It's not long at all.
And so the prompt is how many times the white team passed the ball to the white team. So you're watching and it's just, they're kind of, it's almost like that street game.
Yeah. Or you're at a baseball game and the hats are moving underneath.
Exactly.
Yeah. You're just
exactly,
paying attention to the ball.
So in the middle of this thing, there's the 3 people wearing the black t-shirts, the 3 people playing, and the white are passing to the white, and the black are passing to the black, and smack dab in the middle, so about 15 seconds in, give or take, someone in a gorilla suit walks right into the middle of the stage, beats their chest, and then exits stage right. And the majority of people don't even see it. I was one of them. So here we have people call it illusions, right? And it's not. The only thing that's illusory is our perception, right? So this is what technically happens. So there's a model of cognitive theory called the Bayesian brain. So Bayesian inference is like a mathematical modeling of how we change our mind, or how we really, from a technical perspective, they use the Bayesian inference model to describe how the brain works. So I'll just talk about the Bayesian brain and be like, okay, there's really 3 components to it. Our perception is generated by 3 components. There's the raw sensory data. This is what we're taking in. So our eyes, and think really technically, because I think we don't respect the specificity of the tools that we use to map our conscious experience. Visible light is like 0.0000035% of the electromagnetic spectrum. So these things can transduce photon activity and generate color between this frequency and this frequency. The only problem is those frequencies sit on a spectrum, but these tools don't work that way. So we have this weird grab bag of tools that we've evolved, not for truth, but for survival, For some reason, seeing gamma rays does not, I mean, if you live in Chernobyl, seeing gamma rays may be useful, right? But like we just have this small window into what reality may be, right? So you have this very specific, almost crude sensory tool, right? That feeds you this information. And now, so you have raw sensory data. That's a component of your perception, undoubtedly. But this comes down to the point of like, and this will tie back into pain, and pain is a perception, because pain is a really visceral vector to understand this whole thing. We'll give some examples when we're done. Is when we use our eyes are just feeding us sensory data, just feeding us photons. But when we look at this Bayesian equation, we go, okay, we have raw sensory data, sure. So perception equals raw sensory data and prior experience. Right? Prior experience is a big component of how we perceive things. Yep. Right? And this will be true when we talk about pain. Like, you know, I the last 6 months I've been back and forth a lot between Colorado and San Francisco. So San Francisco, you know, bustling metropolis city. If I'm sitting at a coffee shop and I'm just, you know, on my laptop doing my thing, and a four-legged creature enters, and you know, you maybe hear like the nails on the tile floor or whatever, and you see the general side. Maybe it's a big dog, you know, maybe it's like a Pyrenees or something like that. I've never seen a bear in San Francisco. I don't think it's ever happened. I have no prior experience of seeing bears anywhere. Right? I've seen, you know, maybe out in the wild or something like that, but not in San Francisco. My brain, as I type on my computer in my peripheral vision, is actually generating a dog. Mm-hmm. It's generating a dog based off my prior experience.
Because why would you generate a dog?
Because why? But how do I change my mind? In this case, how do I change my mind? Because I want to lay out another example. Say I'm in Colorado, rural Colorado, an hour away from Rifle, middle of nowhere. Bears everywhere. Say I'm in a coffee shop. Type. We can equate for all of the variables, the amount of sensory data, the sound, the distance, what the scene, everything. It will take far less sensory data for my brain to generate a bear when I'm in Colorado. Because my prior experience, I've seen bears in Colorado, right? That fucking thing would be swatting my laptop out of my hands before I realized in San Francisco that there's a bear in front of me. So far, my brain thinks, Bernese Mountain Dog, right until that thing is here. But when I'm in Colorado, my perception will change because my prior experience will feed this generative model, and I will generate bear much quicker.
Yeah.
Right? Like when you think you see something, you see it.
Yes. You see what you're looking for.
You see what you're looking for.
Or you're used to seeing.
What you're used to seeing, or what may be normal to see. Because there's another value in this that's called a normative value. Do bears exist? Yes. Do bears exist in Colorado? Yes. So that's like at the denominator of this equation. So we have raw sensory data times prior experience over a normative value. That is how we generate our perception, right? So let's think about this in a pain context. A very circuitous answer to your question. But like when we look at pain and we think of like, okay, what is the raw sensory data of pain? It's the nociceptor, right? So the nociceptors are free nerve endings. They transmit through the spinocerebellar tract. You know, they terminate in the somatosensory cortex. Pain is complicated, but nociceptors are the sensory component of this. So if we look at this equation and we have raw sensory data, that first thing, right? In our previous example, it was what our eyes were taking in, like what photons are hitting the macula, the retina, and transducing this signal and processing it through almost like a computational, logarithmic, and interpretational processing of the brain to give us, like in our conscious theater, this image that we generate. Like, not to go too matrix, red pill, blue pill, but like, the idea of reality is like, that's a bit of a dicey subject. What do you mean reality, right? Like if I was a bat, what would our reality look like? Well, it wouldn't probably look like anything because they are using a different set of transducers and taking in a different set of stimuli. They're working on a whole other part of the spectrum. So it's like, okay, but this explains the difference in perception from blue dress to gold dress. And in the case of this gorilla thing that we'll kind of get back to, like, why is it that some people didn't see the gorilla? Right? And it's not that they didn't see it. It's not, they just didn't perceive it. Because sight has to do with just the sensory data. So think of this example for pain. And I know we're kind of bouncing around, but we'll land it. We'll land it. When we think about pain, I think of two things. I think of there's a case study in the British Medical Journal about a guy who fell off a ladder at a work site. and landed on a 15-centimeter nail, went right through his boot. Unbelievable amount of pain, right? They were pumping him full of like fentanyl and Dilaudid and morphine and like really hysterical, like could not, and pumping him full of drugs and nothing was helping. Like it's kind of wild. Like I don't know, like I've been, and one, I live in Tenderloin, so I see what fentanyl does to people. And two, I've been in the hospital before and taken Dilaudid and morphine. Like not, they had it administered, right? You don't feel shit.
Yeah.
Right? Like you're floating. So here you have a guy who's, 15-centimeter nail right through the boot. Fentanyl blood, what is this going to do? It's like, well, it's going to knock out that nociceptor, right? You're going to completely desensitize that thing from sending a signal. So they go in, they x-ray him. Right between the toes. Not an ounce of blood, not nothing. So he was in real pain. He was absolutely in real pain. Stu was even going through. Well,
because you're supposed to be in pain. Because why would it not be in pain? Because you're just seeing it through
you're perceiving everything.
Okay.
And then how do we generate our perceptions? Well, his prior experience and the normative value upweighted his perception that he felt pain. Let's talk about the monkey illusion thing. When you're told, look for how many times the white team passes at the white team.
You're not looking for the gorilla.
You're not looking for black. So here's how it works, right? The gorilla is a bipedal. It walks in on two legs. Your mind is down-regulating the sensory input from anything that's black. And it comes in standing on both legs. Now, it came in crawling on four legs, may be different. But so you're upweighting the value. You're taking white, you're turning it up. Well, at the same time, white and black are different. If you did this with like white and gray or white and orange, it may not work. But these are on spectrum, right? This electromagnetic spectrum that we perceive in this raw sensory data, we're working over here. So most people turn the attention in their conscious theater for black all the way down because they're focusing on this. And the attention is what drives your perception. So that raw sensory data is not giving you the fucking monkey that comes and beats his chest because it's all black and it's standing on two legs. Okay, it's the black team passing the basketball that I'm not looking for, so I don't perceive it.
Yeah.
If you don't perceive it, it's not even there, right? So it's like, so this equation, this Bayesian brain equation, when I'm dealing, so let's bring it into our world. But when you understand that, you now have a really useful framework to start to manage pain. So like one of the things that you have to, when you're in the post-op rehab world, when you do rehabilitation and you understand that these are the components of our perception and that pain is a part of our perception, we can now be very effective in how we really just treat people, right? Because we understand how they generate the perceptions. And so let's walk through this from a post-op standpoint. We have the raw sensory data of pain. Like, have you ever seen some orthopedic surgeries? You joking me?
Like violent.
Yeah, like when they're in your post-op and they have the little tray of all the tools, and then when you go under, they just bring out like Makita, ham and steel, and like, it's like chainsaws. And it's like, oh, I think I have that miter saw in my house. Like that's going through your rib cage, dude.
Yeah.
Like, so there is a nociceptive raw sensory data component that's there, right? That is there. Because one of the other things is you can have tissue damage. So we talked about the guy in the boot, right? So nail went between the toes, no tissue damage, ton of pain. If we MRI'd 100 people, and they've done this research study a handful of times, we MRI'd 100 people with lumbars or with no low back pain.
Yeah.
52% are going to have disc protrusion.
Yep.
So here we have the presence of an injury without pain. We have presence of pain with no injury over here. So this perceptual Ouija board is very finicky in the way that we generate our perceptions. So when we look at a post-op case, raw sensory data is going to be through the roof. So what are our options here? It's like, well, we minimize this. This is why early days post-op, you're going to use medication, right? You're going to use things like ice and movement, passive movement, anything that will decrease the sensitization of pain, right? Can we pull out inflammatory markers of the diet? Because what does inflammation do? Inflammation increases the sensitivity of nociceptors. So we're going to get hairpin triggers on those nociceptors that experience a tremendous amount of pain. How can we dampen that signal? But that's not the only way we perceive pain. That's the way we perceive the sensory component of pain. But what about the idea of prior experience? It's like, can we use can I put you in situations where you know to not fear movement, right? Passive range of motion. So rehab starts before the thing I will do the exercises that we're going to do in the early stages of rehab in the weeks leading into a surgery. So we have an anchor for this. We know this can move without pain. Right? So, in the case of like a knee, I may do some ankle mobility stuff, some straight leg raise stuff, all passive. weeks before it's clinically necessary to introduce any sort of analgesic passive modality at all. Because the thing about some modalities, like whether it's soft tissue work or it's kinesio tape or whether it's vibration or skin stretch, all of these things, what I just listed, and I'll kind of succinctly put them in order for coaches: vibration, skin stretch, light touch, and deep pressure, or what are called mechanoreceptors. We have free nerve endings. So nociceptors, where there's sort of two speeds, slow pain and fast pain, they transmit that signal of like, hey, the switch is on, our brain feels this, our mind feels sensate, or our mind senses, as a part of the larger perceptual apparatus, senses that there's pain here. So these mechanoreceptors is light touch, deep pressure, skin stretch, and vibration. And if, like, let's linger on that. What did I just describe? Look around this room. Light touch, deep pressure, vibration, and skin stretch. I don't know, kinesio tape, foam roller, compression gear, cupping. Like, name a passive modality in pain management, and I will show you something that can link directly to 1, 2, 3, or all 4 of those mechanoreceptors. Why? Mechanoreceptors get to the brain faster than nociceptors. Now, do they fix pain? No, because pain is a perception that's fed by raw sensory data.
Just like in case of emergency, break glass. Low back's tight, you've been sitting all day, you've been on a flight. I like to kind of check in on this, just given the volatility of the lumbar spine. So kettlebell handle, like this is basically trying to reproduce manual therapy. Yeah, this is something that I would do any patient of mine on the table. If I'm not around, teach them how to do it themselves. When we're dealing with low back issues, a lot of times we focus on the site of pain, right? Perry Mickelson said, if you focus on the site of pain, you're lost. So we think that just because our back gets tight, it's the external musculature of the deep spine that's the cause of it. It's like, that's probably more the light on the dashboard. You run the code, the check engine light, the psoas is really part and parcel to the focal point of a lot of issues with the low back, especially acute stuff that kind of flares up every now and then. So what we want to do is you sort of assume the position, which is great. I like to think of my landmarks for this as the belly button and the pocket. Okay. And we're going to draw a line between the belly button and the pocket, and we're going to intersect that line on like a 90-degree with the corner of a kettlebell handle. Depending on your size and shape, anywhere between 25 to 40 pound bell is probably going to be where you want to be. So kind of getting that on the angle, so we're really getting the corner. Now, a little bit of a posterior tilt in the pelvis. One of the big things we want to focus on is breathing. Now, if X marks the spot, you're going to be like, you're going to struggle on the breathing side, but really try and focus. And the reason being is that the psoas actually has a fascial attachment to the diaphragm itself. So a big part of aberrant breathing patterns, they can be causal to a lot of these psoas central low back issues. So we're going to bring that handle kind of, just there we go. So you end up sort of somewhere around the belt line, and then we're just going to get the hip into flexion and extension. So you can start, and if you struggle finding a posterior tilt, you can bring that knee right up there. In order to get that hip flexion, you should be tucking that pelvis underneath. A good mental landmark to think about is the curve of your low back. If your low back is arched and there's daylight under your shirt, probably not in a posterior tilt. So we want to make sure we kind of flatten that lumbar spine, tuck that tailbone, and now we just want to kind of slide that heel over the ground. And when we get to the bottom, I like to add a little bit of a glute flex, trying to almost drive that heel down and bring the pelvis up into the bell. So we're going to try and extend that hip, push down. So push down, drag the heel into the ground, and try and bridge. Good. And then I want you to think about tracing it. You can move it up closer to the belly button. Sometimes people, depending on their previous injuries, I may have them trace the bottom aspect of the ribs and actually try and get into the diaphragm itself. Like we're aiming for a certain level of specificity, but within reason, right? Like the psoas goes and attaches onto the lower T-spine, lumbar vertebrae, but they're on the back. Like we're talking to the back of your body. Now, there's some fMRI studies that actually show that you can reach this with deep pressure. Right? So your organs are just, they're flying out of the way, and you're able to get some stimulus into the muscle itself. But everything along the way is useful, right? Everything along the way, like the fascia, the aponeurosis, all of these tissues, even the skin itself, they're all receptive to that stimulus, the skin stretch and the deep pressure. Like these are all lock and key mechanisms that are responsive. So play around with, explore, if you would, kind of different angles, different depths and pressures, different movements, inhalations, exhalations, and just do it both sides. This is something that I pull off the shelf fairly frequently if I'm sitting a lot, if I'm traveling a lot, if my hips are tight from a particular lift, if my runners that aren't getting into a ton of hip flexion extension, like just getting some stimulus into that region that's responsible for controlling hip flexion extension it's such a palliative measure that's so efficient that if I can't get to people, this is something that's in the majority of people's movement prep, or something that's even away from training in some cases.
So I have this point on the corner of the handle, and I found my point that I'm going with. I'm about to lift my leg. How many like reps, if you're coaching someone remotely, you're just kind of giving them guidelines.
Yeah.
What are you going to kind of hint at here?
So with most of my mobility drills, I actually like to, especially when we deal with the psoas, I like to do it for breaths.
Okay.
So I like the movement to be continuous, but the variable to be the breath. So I'll
do the exact same thing.
I'll designate 10 to 12 full inhales and exhales, but I'm pushing the depth and range of the breath. Like, hey, try and get a deeper breath in. So I may shoot for them to get 3 full passes of hip extension on a single breath.
Holding that extended limb position.
Moving through the breath becomes the variable, because I want the diaphragm to pick up that psoas and that ligamentous attachment at various intersections of hip flexion and exhalation. So I don't want to be breath in, extend, breath out, flex. I want to have, hey, let's see if you can take an inhale over 3 reps of the hip. All right, so on this inhale, make it nice and slow, and then move that hip 3 times as you slowly keep inhaling, keep inhaling, keep inhaling. All right, so we're going to get some good dissociation between that hip flexion extension cycle and the inhalation exhalation cycle, because what we're trying to do is we're trying to create some relative movement between the diaphragm and the psoas.
Instead of just having the typical response of inhale, brace.
That's usually part of the problem, right?
Yeah.
Hip moves through a particular range.
Yep.
Hip moves through a particular range.
I got really deep in that with fighting, because with strength training, it's always big breath, brace. Where in fighting, it's not big breaths, it's sips.
Yeah.
It's just trying to find a point of stability. But then as well, I have to be very comfortable when I don't have that, still being able to punch, still being able to take a blow, because I have to constantly breathe, and I don't have this expectation of when they're going to throw something or when I need to move dynamically.
Well, and the big breath is a sympathetic driver. If you're taking these and you're in a scrap, you're going to gas out way too fast, because inhalation is linked to sympathetic drive, where exhalation is linked to parasympathetic drive, right? You get good news, sigh of relief. Someone breaks into your crib, it's fuck, like, let's go, right? So you got to be very mindful in the way that this affects not only like the state and length of the tissue, but the state of the nervous system as well. Like, there's a lot that goes into, because we talked about function before. Function is the intersection of walking and breathing. It's like, good luck breathing without a diaphragm, good luck walking without a psoas. That intersection is pivotal.
So as a coach, I mean, I got a couple points here. So now, for one, pain.
Yes.
Where does that perception start? Because now that I really think about this, I mean, is this something as simple as when my child falls, when my kid falls on the ground, or now they're much older, but I don't worry, I don't run to them, and I don't go, oh my God, are you okay? I instantly laugh. And I'm like, oh my God, dude, get up. Like, look, and so they're like, oh, I don't need to be in pain. Like, but if you run over and you're startled, oh my God, then it's like, they instantly like, oh, I'm supposed to be hurt. Like, oh, I'm supposed to express that I'm in pain right now.
That's the normative value. And it's a great line of thinking for a coach, because it's like, okay, I'm not a neuroscientist. I'm not a psychologist. What can I do? It's like, well, we can change a bit of the raw sensory data. And this is really getting down to the crux of why I love the single leg RDL as an assessment, because essentially what we're assessing for is, how do you carry your center of mass while on one leg? If you're an athlete, you're making your money. I can't think of an athlete that makes their money with 2 feet on the ground.
Yep.
Right? I was a power lifter. Sorry, it's a hobby.
I mean, even if it is a sagittal sport, you are doing 1 foot and moving.
Oh yeah.
But it for me, it's that interaction with the pelvis. and the femur. Like, how can we interact with that? And for me, I think the biggest, whether it's a tactical population, athletes, it's the adductors and internal rotation.
Yeah.
And closed chain movements, I think, are the key with anything, because it is real world. I hate to throw the word functional, but it brings in that aspect of this is life. This is how you interact with your environment on a daily basis. And it's familiar.
Yeah.
It's not an open chain movement that feels weird. I'm not giving you a test for an exercise. It's more of, hey, here's a pattern. How does this feel?
I'm trying to figure out what is this person's relationship with gravity, right? That is the number one. It's like if you're dealing with athletic population, because I've had, wide receivers running 4.3s, and I've had people who are detrained that are, 60, 70 pounds overweight. They will present very similarly. What is their relationship with gravity? Because the external environment dictates the internal demand. Right. So I need to use the conduit of their voluntary experience that they can tell me, I feel it here, 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 to understand that data point. Right. So let's say, for example, you felt it in your calf. Right? So we get into this hinge position, we come down, and I feel it pulling my Achilles, I feel it pulling my calf. What does it tell us? It tells us about their preferred way of carrying their center of mass on one leg. In technical terms, we would say they carry their center of mass forward. Now, there's a couple reasons why that could be the case. One, let's take the position of like the wide receiver.
Yep.
End zone is that way.
Yeah.
Always.
Money's that way.
Money is that way. And they're after the bag. Or take the someone who's like a little bit round in the waistband. Spine is in the back of the body, right? So pulling the center of mass forward, right? Tall people, right? Hoopers are famous for this.
Coming down to society.
Well, why do you think we have so many Achilles? Now, I'm not going to an injury whisper, and like if you're a coach, don't do that. Don't be like, oh, I could have saw that from happening, blah, blah, blah. But think about every time, we get into these positions, we know how to map that movement so that we can find the hip rather than being stuck in the sagittal plane, right? Gastroc, soleus, hamstring, adductor, largely speaking, the adductor magnus, these are sagittal plane muscles that move us front to back. Right, so I want you to think of like when people give you that data point of like, I feel it in my calf, I feel it in my hamstring, I don't feel it in the glute. It's like, well, we're not finding that internal rotation in the hip, because internal rotation in the hip is a movement that exists in the transverse plane. So just like a brief, like aside, we have 3 planes of movement that we move through. If you're a coach, you'd be familiar with this, but let's just do a quick refresher. We have the sagittal plane, which is just like flexion, extension, front to back, very simple. Like the example I always use is, my great-grandma died at 106. By the time she went, she was on snowshoes, cross-country skis. The sagittal plane was all she had left. You take a bodybuilder, you ever watch bodybuilders run? There's like this penguin-like waddle. They're in the frontal plane, side to side, right? Like, and then if you go watch like Bolt or Safa Powell or whoever, Cheetah, all transverse plane. The only thing that doesn't rotate is their head, right? The head just kind of floats, and everything else is just aggressive rotation. So we have transverse plane, very complex. Frontal plane, a little bit less. Sagittal plane, very simple. When we see someone who gets into this position, and more importantly, when we hear someone who gets into this position and goes, I just feel it in my calf, we go, okay, sagittal plane muscle. Feel it in my hamstring. Okay, sagittal plane muscle. You're defaulting to a very simple strategy of locomotion. And you said something that I found interesting earlier, and I think it's a word we need to reclaim, which is functional. Right? So functional, as far as I'm concerned, walking and breathing. Movements that are related to the automaticity of ventilation and locomotion, that's when we start to talk functional. How does this relate to gait cycle and ventilation, the mechanical processes of breathing and walking? Because breathing and walking have a neurological component. They take up neurological real estate in the brain that is part of the autonomic nervous system. This is your default mode network. This is how we move when we're not thinking, right? Like our conscious theater is but a tip of the iceberg to all the goings on of the brain. So I do think there's utility in coaches in understanding a working definition of the word functional. And we can start to tie in some of like basic gait cycle locomotion principles into what we're doing, right? Like essentially what we're doing is as we get into mid stance, which is defined by when I take my foot off the ground, I need my center of mass to come over my base of support, right? So if I'm facing the camera, I'm just go for a stroll in the park. My heel strikes, early stance, foot flat, early stance ends, mid stance starts when my other foot leaves the ground, and then concludes when my heel lifts. So in order for mid stance to occur, I need to shift through the frontal plane. My pelvis is moving to the side. So my center of mass is now right over my base of the board so I can lift. The reason I need to do this is I need to find that closed chain internal rotation of this femur in the pelvis. That allows us to find the glute. That allows us to propel us. You know, the glute fibers in all directions. We can go in all directions. It's the biggest muscle in the body. We can produce a ton of force. So when I take a look at this and I see, oh, we're in the calf, sagittal plane, one direction, not a lot of variability and expression of movement, carrying our center of mass forward. I need to help this person break into the frontal plane to find the transverse plane. So in that case, we would take just a heel elevation. This is really simple. And there's ways that we can layer this because we're trying to like Goldilocks and the Three Bears this expression of like it's a little too hot, a little too cold.
Yeah.
Because a lot of people will think immediately, oh, your calf's tight on a single leg hinge. Tight calves, we've got to stretch.
Roll it out.
Please don't. Well, because like here's the thing, and without going too far, like do you know how, like what does this do? What does a heel elevation do? Because it's an embodiment of this principle that the external environment dictates the internal demand. This is a hill. It's a little hill that we're putting you on.
Yeah.
And the way we carry our center of mass changes given the external environment. So if I were to run uphill, my ass would be back, my chest would be forward. If I were to run downhill this way, I'd be eating shit downhill.
Yeah.
I automatically make these adjustments of like, whoa,
Yep.
I'm pulling myself back, right? Shoulders are low. I'm trying to like get my heels out in front of me because I'm playing this net neurological calculus of where is my center of mass. Downhill is gonna be like, whoa, your center of mass is going forward. It's like, well, when we do this and we think, oh, your calves are tight, we think, oh, you're carrying your center of mass forward. So we're going to put you on a hill on one leg. So then you're really thrown forward.
Yeah.
You ever see Squid Games?
Yeah.
Do you remember when you got addicted to the show? Did you watch the whole thing?
I did not watch the whole thing. I've only seen a little bit of it.
Okay.
I'm more of a Mr. Beast games. It was a little bit too much for me.
Squid Games, anyone? Squid Games? Yeah, seen it? No, you seen it? Okay, the red light, green light game.
Yeah. Okay.
Okay, that's like everyone gets mowed down. It's like fucking Normandy.
Yeah.
What happens is there's the protagonist of the story. He's about to fall, and then his newfound friend catches him. That relationship is how most people go through life. Now, here's the relationship. The protagonist, the guy falling, that's the perception of your nervous system. That's your nervous system's perception of your meat suit in space.
Okay.
We're always just falling forward. We got a spine in the back. So the response is to take all of this in the back and hold you up, right? So people that have tight erectors, my shoulder blades burn when I wash the dishes. It's like, yeah, because your brain doesn't realize that you're falling over.
Yeah.
And it's pulling you up from your erectors, from your glutes, from your hamstring into your calf.
The best example of that I would say is, I mean, I can deadlift the house, but giving my kids or like a bath or like standing over something will completely destroy my back.
Right.
Yeah.
So when you look at that relationship, you go, okay, now when we put you on this, so we're kind of working this theoretical of like, hey, so you're working with someone who's in this, we'll say this in technical terms and we'll kind of unwind it in simpler terms, that's carrying their center of mass forward, but their preferred strategy is to load in the sagittal plane. You feel that tension in the muscle because we have our posterior chain is on high tone, pulling you back.
Yep.
So what do? We're going to push you forward even more. And now your nervous system's going to recalibrate, right? So you go ahead and hinge here. And now look, here's the thing. Very good at it, very well trained, has done this well. You may have to, come back up, you may have to introduce some external support, right? It's all about graded exposure. You ever see Recess? You're around the same age. Yeah, okay.
Yeah.
So look, all right, kids out there, if you were born in the 2000s, you don't know about the wonders of the show. Remember Mikey?
Great show.
Remember Mikey?
Great show. Yeah.
So Mikey is this big dude who could only sing in the bathroom.
Yep.
So what they did was they took all like the urinals and the sinks and all that stuff and they put it in the music room. And they slowly, as he got used to singing, they started putting it back in the bathroom. So he just had graded exposure to this environment that allowed him, get over his fear of singing in public. So if you have someone who, ouch, I feel it in my calf, it's tight in my calf, fuck, I really want to feel it in the hip. I want to find that closed chain internal rotation at 90 degrees of hip flexion, so I know that when I'm asking them to squat or deadlift or sprint or jump, that we are in a prime position for the body to know where it is in space to be able to produce as much force as possible. Like that's when you're in the money. Like if I go home, I take my guitar off the wall, I need to tune it first, because the first note or the first fret of the E string is only an F if the E string's an E, right? So if I'm squatting and I'm jumping and I don't know that I'm finding that IR in the hip, if I'm overloading that posterior chain because I'm stuck in the sagittal plane, I don't know what I'm playing, right? I'm just making shit up, right? So it's about calibrating the human instrument to be like, hey, and like, how do I tune my guitar? Ear. Right? You can do the frequencies and you can run the math, but when you get good at it, I just go, there it is, right? So we're gonna do the same thing here, because now you can do one dowel, you can do two dowels. I sometimes use my treatment table, because it's like, hey, look, if we're not getting that sensory data in the right place, it's a moot point, because I can take 10 people, line them up, get into this position, hopefully not that bad. We're gonna cut that. And then we go, okay, where do you feel it? And we could measure the joint angles. The ankle, like the lateral malleolus to the greater trochanter to the base of the occiput. And we could do it all with 10 unique or 10 perfectly symmetrical presentations objectively, 10 completely different subjective experiences. Because we have 10 different nervous systems that interact with gravity every single day. So I want to make sure that, like, look, if I got a room full of 20, 30 guys, hey, let's bring it to the starting line. Let's pull that guitar off the wall. We got to tune it. We got to calibrate, because I got to know, you guys may get similar programs. I may give a musician similar sheet music, but if I give them instruments that are different tunings, we're going to have a fucking clusterfuck, right? We're not going to have this symphony of a session. So something like this, where it's like, okay, what are we trying to do? We are trying to get the nervous system on board with having a center of mass over the base of support as calibrated by the autonomic function of muscle, right? The sensory component that adjusts. Because what happens is, if you go into this position and just give me a speed wobble, right? So you see this, what's happening? Well, the lights are out, right? We see these gross overcorrections because we get the lack of utilization of that muscle spindle. So what happens is as like, well, I'm going to do this kind of slow. As this happens, right? So as like, I kind of close down and I close down too aggressively. What's that? So my glute is lengthening. The fibers in between, these interfusals lengthen. The muscle spindle stretches, and it stretches fast, and it goes, hey, get back, contract. So then these guys, the fingers, they contract. But if you haven't done it a lot and you don't know, your body can't render this 3D motion capture image of where it is, it's a gross overcorrection, right? It's like, whoa, it's
They're just bouncing out.
Yeah, you're right. But when you get good at it and you get this positional awareness and you can control your center of mass, when we watch you do it at the onset, it's just very subtle, right? Like it's these minor adjustments, and you just see the corrections. Like, oh, you're good to go. That's what I love about this as an assessment, because how does it change? How does it change? Because that's the money question, right? Because an assessment is a question. And what gives questions meaning? The meaning comes from how the question changes your action. That's the definition of what's meaningful.
Why are foam rollers so ubiquitous? Why are they everywhere? Right? Because we can sit there and look through this pigeonhole of sports science and go, foam rollers don't work. They define work. Well, they don't break up scar tissue. It's like, oh my God, like what are you talking about? Like,
I'm gonna be honest, that is a soapbox that I used to be partake in, like, oh my God, that doesn't work. And now if I have a client that brings a foam roller, I'm like, that now we have a bridge to communicate. You care it somewhat about recovery, about your body, that you have took ownership to bring a foam roller to a gym.
think a little bit about how the foam roller fits this model. It's like this thing is pulling two things up at once. It's changing the raw sensory data, right? A foam roller is going to apply deep pressure stimulus, which is a mechanoreceptor that fits in this model. We have nociceptors, mechanoreceptors, and proprioceptors. But it also has this normative value to it of like, hey, I saw on this thing that foam rollers help reduce pain. Okay, cool. Foam rollers do foam rollers. Yeah, okay. But I have prior experience of it. So now you get this compounding positive feedback loop. So now
is that the only mechanoreceptor that we could stimulate? No. Like, is strength training long-term going to be the thing? Yeah. Why? Because muscle spindles and Golgi tendon organs are part of this raw sensory data matrix. Nociceptors up here. The nociceptor's slow as fuck. The real straight dope is in the loading. Why? Because muscles and tendons and joints, these things respond. Their lock and key mechanism gets to the brain, Jesus, 135 meters per second. So like we know that we can, that yeah, sure, the real way to, again, we fix on scar tissue. It's like we're chimpanzees with universes for brains, and we're focusing on scar tissue. Like get out of here, please. Like just shut up. Like please, like let the adults fucking handle it, because it's like there's so much more going on than what's under the microscope of really remedial sports science. It's like when we understand how this changed their perception. Like you said, someone comes in with it. That's buy-in, dude. Like that's, and
They're there for a reason.
But what do fucking smart coaches do? They try and be smart. They try and be cute. They go, we're not going to do that.
Yeah.
Like, don't take the ball out of his hand, you fucking idiot. Like, yeah, we're twice on Sunday.
Yeah.
3 times on Jesus' birthday. Like, we're about this light. Now I'm going to use that as a small end of the wedge to break the door open.
Absolutely.
Right? But
It's an opportunity. A foam roller is an opportunity.
Massive, right? Anytime we see a palliative measure in place, it fits this model somewhere.
Yeah.
Now, like, you're back to my like rehab thing on the pain to coaching. It's like, okay, look, when we look at performance, right, there's 2 components to it. So when we get someone, like say in a rehab setting where it's like, okay, I'm going to start off going through passive range of motion. We've done this for weeks prior. She knows this to not be painful. So I'm already decreasing the perception of her pain. The nociception's there, don't get me wrong. Now we're using pharmaceutical aids, and we're using ice, and we're using compression to decrease this. We're using motion to decrease it, but we're using the prior experience of that pain-free motion to start closing this loop. And then once she's every single day, how does your knee feel? It fucking hurts. And I go, good. What do you mean good? Of course it hurts. And you show them a video of the fucking baseball bat they used to jam in their new tibial plateau. It's like, yeah. You're wired up right. I think, oh.
But I have this thought of mental scar tissue, which you mentioned, lasts longer than physical scar tissue. Like once we've come accustomed to pain, it almost becomes our personality. Like I expect it now. So when you have someone that's constantly in pain, that's just all the time, but you're doing this assessments, their performance is up, they're operating good, they're progressing normal, but they're still feeling in pain. How do you bridge that with them? How do you break that loop or get them out of that mindset?
Yeah, it's funny because when we think about common, we talked a little bit about this before. You said a few things on the car over that kind of struck me. One is like, what are the common ways that people in these scenarios look to get out pain? Like there's 2 common fields of study right now that are really emerging in people with chronic pain, PTSD, and things like that. And not to lead the witness, but meditation and psychedelics. Right? Meditation and psychedelics right now are sort of leading the charge when it comes to why. Right? Because they change your perception. Like what drugs do, allegedly,
alters how we see things.
But because it removes our priors. Like when you take a healthy dose of psilocybin, what it's actually doing in your brain, it's wiping your priors clean. Like, take for example, and this is a bit of a tangent, and I hope I can bring this back, but like, have you ever dealt with concussions? Okay, so there's this phenomenon, and if you guys like WebMD concussion symptoms, you'll see that you have like your litany of expected symptoms and signs, right? And one of them that's on the bottom of the list always is impaired visual saccades. And most people go like, I don't know what that means. Okay, just like don't stay away from technology and light rooms and all that stuff. And so they pass it over. No one knows what the fuck that means. So what a saccade is, and this plays into our whole conversation that we're having, hopefully comes back to this idea that like, okay, how do we change the perception with movement? A visual saccade is essentially, if we were to take high-speed cameras, right, and we were to get Calvin to film our eyes, and we're slow it down frame by frame, 3 to 5 times per second, our eyes are darting around, which is crazy because I'm staring at you right now, right? And it's my eyes as little video cameras. My perception based off of the way they're moving, they're darting around right now. I know they're doing it.
Now I'm thinking about it. I wish you wouldn't have said it. But now I'm very obvious that my eyes are moving around. Yeah.
But even more than you can perceive, they're moving faster than our perception will really allow, technically speaking. So touch your nose to your finger to your nose.
we know that the transmission of this signal from the pressure of my finger to my nose should arrive earlier than my finger, but it doesn't. We know that our eyes move 3 to 5 times per second, but we get this steady stream, right? Like I see you. My perception of you should be like the fucking Blair Witch Project.
Yeah.
You know what I'm saying? It should just be, if these are
stabilized.
well, it's predicted.
Yeah.
So when I do this, I feel my finger pressure, my nose pressure at the same time. Our body just put that together and offered it up to us, right? Like, so this is when we talk about like reality and what is real, it's like, this is all generated, right? So when we start to think like, okay, how do we deal with pain? Like when we think of meditation, when we think of psychedelic, what psychedelics do is they scrap your priors. They go into the part of your brain that allows you to draw from previous experience, and they go 404, forbidden page not found. It's like, holy shit, that cloud looks like a fucking gazelle or something.
Yeah.
Like that gazelle is talking. So you have no prior experience of clouds not talking to you anymore, right? So now anything's up for interpretation, right? That's one of like the fundamental high level mechanisms of how a lot of these drugs work. They scrape your priors. Like, I mean, I'm not going to incriminate myself, but some drugs are known as dissociatives, right? Very commonly used in the PTSD space. And like, until we say the word dissociate, and we may use it in a technical term, like dissociate the position of the scap from the ribcage or the femur from the pelvis. But like, you don't really know what that word means until like you see Buddy in a K-hole and you're like, oh, that's dissociation. Like it's complete removal. But what are you dissociating from? You're dissociating from your priors. You're dissociating from the way that your environment offers you this part of the perceptual equation that generates your reality, right? So when we look at exercise and movement, because one thing you said in the car, and it really struck me because we see things in a similar way. We communicate a little bit different, but you're like, man, it's really cool. Like, I'm just really passionate about movement. Movement, when we put it in, like movement should be seen. And like, I think resistance training more specifically because of the way that it triggers these high priority, these high speed to transmission proprioceptors, like the way muscles get loaded. That should be seen as in the same realm as meditation and psychedelics. Because it offers us very potent, like other than our eyes, which can be affected in training, muscle is the most predominant sensory organ in the body. Raw sense data, especially when we start to factor in that, look, mechanoreceptors, which are a set of 4 receptors that are found in our skin that transmit deep pressure, light, touch, vibration, and skin stretch. And then proprioceptors, which are joint capsules, muscle spindles, and Golgi tendon organs. And we think about, okay, we take this pool of raw sensory data that we pull from, and we think that, okay, nociceptors are here, right? Nociceptors are slow, 0 to 20 meters per second. Mechanoreceptors are here, 35 to 70 meters per second. Proprioceptors are about 120, 130 meters per second. Movement gives us access, exercise gives us access to this, which this plug better information, sensory data into this equation. And then you have a framework where it's like, cool, drugs play over here, right? And look, they all there's overlaps of Venn diagram. Like I'm using these clear buckets of differentiation for like scholastic academic purposes. It's a lot more messy than you think. But if I go, okay, I can use resistance training to feed this perceptual engine with better raw sensory data, that can change your entire perception, right? Just like fucking psychedelics, just like meditation that work in other normative values and prior experiences. Great, cool, let's train.
Now, a couple of things I want to unpack out of the gate that are really common. The focus on the foot and ankle complex is something where a lot of people sort of bet the farm. Weak ankles, unstable ankles, which are possible and true, especially if you deal with sports. Hoopers are going to be rolling their ankles all the time. Wideouts are going to roll their ankles all the time. So there may be some structural instability, but I want you to think about, pass me that dowel. I want you to think about what it is we're seeing. Now, Vern's solid, so he goes through, go ahead again. We're going to watch the foot and ankle closely. So we're seeing, there's some adjustments, right? And so come back up. So we can see kind of those flexor tendons at the front of the ankle, sort of turning on and off and on and off. And we don't want to lose the forest for the trees. A lot of people look at this and go, yeah, like my ankles are really unstable. They're really weak. And it's like, sure, maybe, but you're a big ass fucking dude, right? So people may focus on that and think, oh, there's a tissue tolerance issue at the ankle. The ankle isn't strong enough. And then we get out the towels and the soup cans, 235, 240, like, that's a big soup can,
Yeah.
You know, because what's happening is like, if we take a look, we consider this the lower extremity, right? So the hip up here, say the knee is here, ankle's here. What you're seeing is this, right? Like our foot is trying to make these adjustments to keep sort of the center of mass over the now limited base support. But it's really, and this digs to a fundamental issue in a lot of applied biomechanics. We look at this and we think, oh, it's a tissue tolerance issue at the ankle. But biomechanics and injuries and force production really have two components to it, right? There's applied force, right? And there's tissue tolerance. So someone may look at that and see sort of this wobbly ankle and think, oh, we need to improve the tissue tolerance at the ankle. It's like, why don't we change the way we apply the force, right? So when I look at this, really what we're doing is we're assessing the stability at the hip, right? So it's rather not so much the tissue tolerance here, but why are we applying so much force to that tissue to begin with? So that's like red herring number one. A lot of people go into this drill and they look at it, and look, very well possible that you may have pre-existing foot and ankle instability issues, right? Ligamentous tears, you're rolling, spraining ankles, deltoid ligaments, anterior talofibular ligaments. Like, those are real concerns. If you can take a good history, you can begin to circumvent those accordingly. But for most people, most of the time, even for those with previous ligamentous damage to the foot and ankle, what are you going to do about it? Yeah. The big rock is still, let's decrease the applied force, right? And so much, especially, you know, coming from my world in the more rehabilitation space, so much of like the archaic focus is on building tissue tolerance. We got to strengthen, we got to strengthen. It's like, dude, the only way that this math works out is if you lose 130 pounds, right? Like, you're always going to be applying so much force to that tissue. Let's see if we can't move that around a little bit better. So that's sort of like step number one. So I want you to kind of put that aside at first. Now, the second thing, I want you to kind of get back into that position again. Now, again, you're very, what I would call stable. Now, so come back up. When we watch that, and let's try and think of the different expressions of this exercise. Like, how does this look when someone who's unstable performs it? And before we get into it, I think talking about stability as a separate adaptation from strength is a very important neuromuscular physiology principle that we kind of need to wrap our heads around. Because when we deal with applying force, like, imagine a knee that is succumbing to this instability at the hip. People don't like the word stability because it's not quantifiable, right? It's not a metric that's objective.
I would say the same thing the way people throw around tissue tolerance.
Sure.
It's become a buzzword of, oh, the tissue has to be more tolerable to load. Like, what does that mean?
Right.
What does that mean?
So I think from a point of stability, like if we're focusing on the hip with this exercise, let's compare an exercise like a single leg RDL to like a banded monster walk or like a side lying abduction. And let's think about the muscle. Let's pick one at random. Let's say the glute med. Glute med, you know, most of you should have some familiarity with it. Think of like the deltoid, right? So deltoid, we kind of got this spot where our delts start, fans up in and around the shoulder. Glute med is like very similar anatomically. It's just the lower extremity version. So we got fibers that kind of run up to the front and posteriorly, and like our medial fibers of the glute med. So we kind of have like a butt delt. Yep. Right? So we can do exercises like this, which are like more open chain and strengthening. And when I do this, I'm going to think about like how this happens. Like, think about the processes that have to occur for this to happen. You know, your parietal lobe, your frontal lobe, right at that intersection is your pre and primary motor cortex. And this is where like our motor patterns have like a Dropbox folder. And we go, okay, I'm going to voluntarily go through this action of, you know, hip abduction that goes down through the requisite spinal nerve, out through the anterior spinal nerve, and then the whole depolarization of muscle contraction, sarcoplasmic reticulum, troponin C, I think. It's been a while, but that happens voluntarily. When you're standing on one leg, now, mind you, this is kind of a gross oversimplification. When you're standing on one leg and you're hinging, what we're watching is we're not watching a voluntary contraction of the muscle. It's not like Vern's thinking like, oh, I need contract, relax, contract, relax. It's essentially what's happening is one of the big components of neuromuscular physiology you have to realize is that muscle at its core is a sensory organ, right? It's the second most abundant sensory organ in the body, right? Our eyes are first, but I know where I am. Mechanoreceptivity is a part of it, like my skin and the layers underneath my skin have senses to vibration and skin stretch and deep pressure and light touch. But muscles have what are called muscle spindles, right? And Golgi tendon organs and joint capsules. These are our proprioceptors. Now, we use the word proprioception at our peril a lot of times because people think that general kinesthetic awareness is proprioception. Those words get melded together. Proprioceptors are a specific classification of free nerve endings, which are joint capsules, muscle spindles, and Golgi tendon organs. Right? So as the name suggests, we can probably tell where these things are. Joint capsules in the joints, so Golgi tendon organs in the tendons, and then muscle spindles, obviously in the muscle. Muscle spindles are the most abundant by volume in the body. So our muscles are sensory organs. We look at them so often in training as these units of output that need to be strong. But when we're here and we're getting into some of these positions, there also can be tuned to be sensitive to the change in position that comes with the deviation of center of mass over a base of support, which is the dictionary definition of what makes something stable or not. So when we're watching the foot and ankle kind of oscillate, we're watching a voluntary reactivity to this muscle.
Yeah.
So as we see the position of the knee and the femur is moving, so what's happening is there's a process of neuromuscular polishing or sharpening, because obviously you're kind of known for this, right? Like you do a lot of unilateral single leg work. Now this is where, for a coach's perspective, where you want to be very specific, and this is where understanding the neuromuscular physiology becomes useful. Think of a muscle, like if you look at my fingers here, okay, and think of my fingers that are touching as like if we were to lay this over your bicep, say this is a bicep, okay? There's two types of muscle fibers. And this is where, depending on your influence, some of my early coaching influences talked a lot about fiber type training, right? Type 1, type 2, fast twitch, slow twitch. You know, your calves are small because they're type 2X or type whatever, you got to train, whatever. But for me, it's really more the meaningful differentiation of muscle fibers is not fast and slow twitch, glycolytic, alactic, any of that. It's intrafusal versus extrafusal, right? So not many people have heard these terms before, but it's really meaningful in the conversation when we're digging down to how does this assessment set our trajectory for, you know, the exercise prescription past this point. So if we think of a muscle like this, and my fingers that are connected are what are called the extrafusal muscle fibers. These are the ones that they're the contractile elements of muscle. But if we think of the spaces in between, these are the intrafusal fibers. Right? So there's non-contractile elements of muscle that carry the sensory data of position and change in velocity, or change in length and magnitude of stretch. Right? Those are your muscle spindles. Those are what tell your brain where your body is in space. Right? Like so you're walking down the street, someone kind of like brushes by you and hits your elbow. You're kind of like, whoa, dude. Someone tries to rip the watch off your wrist. Your reaction is it's graded. So your motor output in that sense is directly dictated by the magnitude of the sensory input. Sensory input dictates motor output, right? So many people try and get stronger by just driving more output. What's a good way to get more output? Find more stability. Why can you leg press more weight than you can squat? For sure. Because you have more external stability. Yep. So, and not to say that periodization principles aren't useful, but until I can qualify a movement, the quantification of it is useless. So if I see someone who's, you know, squatting 300-400 pounds, but they can't stand on one leg, it's like, oh, this is a massive rock for us to turn over. Now it's not going to get us to 700-800 pounds, but it's going to be able to create some really useful sensory data that's going to allow us to drive further motor output, right? So when we look at this exercise, and we'll kind of bring this, hopefully we'll land this from the advanced neuroscience. But like, I want you to think about what happens. So again, your left hip is going to be really stable after this. So what's going on is there's an autonomic response in the way he's carrying the combined center of mass, all the forces acting in and on the body to keep it over his now limited base of support, right? Which would be somewhere through the midfoot. And we're watching this oscillation. So when we see the polishing, the micro adjusting, that's these muscles at the hip calibrating the position of the femur in reaction to the deviation of the center of mass. And it's very subtle. Let's come back up. Now I know when I see this, and especially when you go, where do you feel it?
In my hip.
In your hip, perfect.
Yeah.
Now, the thing that coaches need to pay attention to is when you deal with people athletes, general population, who are, maybe let's just say bad at it, like not great at the execution of this movement. And here's the bitch of it. The execution of the movement is subjective. Does it look good? Does it look stable? And coaches have a hard time with this. It's like, no, this is why we have a job.
So when you think about starting someone, you get this new athlete, this new client, and you're bringing them on board. And we don't understand where they fall in that spectrum, but you know they're coming to you for a reason. And it's probably because they're experiencing some sort of pain, discomfort, rehab, surgery, whatever it is. How do you assess that person typically upon intake to kind of find out where they're at?
History,
Without a doubt. I mean, any good
Stop where you're at.
go.
One of the best things I've been told from a mentor, Mike Hill, used to be at Georgetown University. He had a diagram and it was B and C, or maybe he had 1 and 2. I don't even remember what it was. And he said, coaches are really good about taking someone to the start line and putting them to the finish line. Hey, you sit down with them, hey, what are your goals? And they go, oh, here, formulate goals. I can formulate a path given everything. And he said, you want to know what really matters? And he drew the line backwards. And he said, where'd they come from? What drove them to find you first? What caused all the issues that got them there? Who is the person before they were right now? And that, I kind of get goosebumps right now. It changed how I look at clients now, because now it's not this person that needs me now. It's who is this person before they got here?
No, yeah, without a doubt. I mean, that's when it comes to programming, when it comes to periodization, when it comes to progression, regression, when it comes to like because assessment is exercise execution, complexity, load tolerance, all of these things are premeditated. Something has to come before that, right? Something has to give me an indication of where do I start with this person, right? And if, in my world, dealing a lot with injury, and much the same to you, it's like, this is the thing is a takeaway. If you're a coach, it's onset, mechanism, progressive, palliative, provocative, quality, radiation, site, timing, frequency, intensity, duration, activities of daily living. You can remember that?
I can't.
Okay, but so here's the thing: if I guarantee, if I sat down with you and just was a fly on the wall, and saw you interact with someone for the first
Probably
time,
covering some of those.
you would hit every single one of those, right? So onset, how did it start? What is your relationship with the scenario that I don't know. I just kind of woke up one day. Very different experience than I was like mid lunge and I heard a pop. Lunge out the door. Like we're not seeing lunge. Now what I might do after a couple of months and I get like my feet wet, I understand, I've scaled some movement qualities. I may do like a split lunge wood chopper and we're chopping the vegetables up,
Nudging them.
spaghetti
Just
stuff.
nudging them.
Well, they're focused on something else. And like, hey, you're just in a lunge. Now we've taken that prior, we start to scrub it.
Yep.
And we go, wait a minute, this is not noxious anymore, right? So onset, mechanism, how did it happen, right? So progression, like, is it getting better or worse? Are they coming to you optimistic? Are they coming to you defeated, right? Palliative, what makes it better? It's a layup. They're giving you the answers, right? They're literally leaning over, C. Okay, and this is where I see coaches fuck this up all the time. Someone goes, yeah, hey, look, I really like, Pilates makes it better, stretching makes it better, foam rolling makes it better, Theragun, kinesio tape, all that. And coaches will just take that and go, nah. It's like, you shut up.
Yeah.
What? This is sure. We have something. We have a small wedge. We have a small end of the wedge in the door already. So provocative. Like, what makes it worse? These are like, this is off the backboard stuff. Like, this is an alley-oop. They're giving it to you. It hurts doing this, and this. Okay, right, we're not going to do that. Oh, it feels better doing that? Okay, we're going to do that.
Yeah.
You're already like halfway to the
Condescending.
best fucking coach of all time.
Exactly.
Right? Don't get cute. Don't try and outthink it. Understand that, look, this fits a model. This fits the perceptual framework. Then, like, if you can, and there's something to be said. There's an intangible conscious experience to coaching that if you can express that you understand in the way that you write a program and be like, hey, look, look, there's none of this in here. Don't got to worry. And you're going to start off with this, and this. Scene. You get, oh my God. Like we've already, it's like, I think of it this way. Like there's, you hear about these sociological studies where they put bean sprout plants in kindergarten classes and, they sing the one Pagliacci and they tell the other one to go fuck its hand or whatever. And it's just like, the Pagliacci one grows into this most magnificent bean sprout and the other one dies.
Yeah.
You see the coach that goes, well, actually patellofemoral pain syndrome is more like the shut your mouth. Shut your mouth. You shut your mouth. They said that this hurts
and you avoid it. And they said that this makes it feel better, and you do it. Like, we don't need a PhD dissertation. You got to shut your mouth and get to work. Right? You can have these thoughts of how we may pull them out of this cycle long term by better sensory data or whatever, but like it's much bigger than you, dude. Right? So palliative, provocative progression, quality. Don't overcue it. Is it sharp? Is it stabbing? Is it shooting? I had a guy once when I was in a corporate practice tell me that his elbow was whistling, and I was like Hunger Games or sitting at the dock of the bay. Like, where's the whistle? Like, where are we at with it? Sure, man, whatever the fuck ever. Now, if he comes in and says it feels like it's on fire and there's like a hot, okay, maybe we refer out, right? Sight, this is another one of those bean sprout moments of like, people go, oh, your knee? Like, yeah, that's a big knee. It's a nice looking knee.
Touch it.
Where? Yeah, dude. Like, is it here? No, here. Okay. And then every day I come in and say, hey, how are we feeling? Knock, knock. I know that you know that I know where your knee shit is.
That is one of the biggest mistakes I see coaches making is they tell them where they feel it. Hey, do you feel this in your quads? And they go, oh, yeah. Yeah. And I had one client specifically where it was just like, oh, you don't know as much as I think you do. We were doing, again, this was years ago, and it was a football player I was working with, and he came in saying, he was like, man, my hamstrings are on fire. And I was just like, oh. So I instantly, I was like, man, what did we do yesterday? And it was like a full body push day. So it was squats, bench. And I just was like, damn, your hamstrings? Like, I mean, we weren't even going deep like that day because he's a taller guy. So he wasn't getting it deep. And I was like, man, I sat there for like 20 minutes. Like while we were warming up and getting moving, I was like, how do you feel this in your hamstrings? And I literally looked at him and I was like, dude, you really feel that in your hamstrings? And he was like, yeah, man. And I was like, bro, those are your quads. And he was like, oh, yeah, my quads on fire. And I was just like, oh,
right.
Okay. So now from going forward, it's like, hey, where do you feel it? And they go, oh, right here, done. Yeah. I don't need you to know the muscle. I don't need you to know what it's called. I don't need you to know the action, the origin of it, nothing. Just touch it. Yeah. Touch it or touch it on me. Where's that? Touch it right. Perfect. Now I know.
Huge. Massive. That synchronization, it plays on so many levels, right? It plays on a lot of this idea of confidence in your prior and your normative values. Timing. When does it hurt? Hurt in the morning, hurt after you lift, hurt before a lift. Some people get in pain before, before training. Why? Because your predictive engine is starting. The same way that an athlete's heart rate is going to start elevating before it gets on the treadmill. Why? It sees this prompt, right? It sees this affordance, and it goes, I know what this is. I predict heart rate goes up. That's why it goes up. Oh, before? Okay, interesting. Oh, it hurts in the morning? Oh, okay, hurt. Duration. How long is it hurt for? Is it 25% of the day, 50% of the day, right? Frequency. Is it every day? Intensity, out of 10. Duration. Like I said, those two are really important. And then finally, the most important, where you're going to get the most amount of data, is activities of daily living. They're not going to be able to speak. You and I can be like, yeah, dude, once I hit in the scapular plane, once I hit about 90 degrees, man, I get this weird pinch to the front of the shoulder. I think it's probably teres or something. Yeah, right. Yeah. Well, my kids were acting up and I went to fucking smack them in the car and I heard a pop and now it hurts to breathe. Like, oh, okay, like, left to right trunk rotation. We can translate. Yeah. We're going to have to grade that exposure. Maybe we, enter with some body weight stuff, some breathing. We learn to load it and we set that. But they're not going to give you the mainline source code of the movement. They're going to give you hurts upstairs or downstairs. And here's the real trick. And this is where things get really creative. Is when you check in on that, that's going to be the first thing to move. The stuff in the gym, we're always going to be kind of bordering on that discomfort. We're trying to make some adaptations, right? Maybe we're doing something specific for that region so they feel like they're really focusing on it. But after a week, you go, hey, did you notice just anything like when you're in the car? Oh, you know what? No, weird. Funny you mentioned that. People have a weird memory with pain. Yeah. How many times have you had this? You'd probably be someone who's had this almost as much as I have, if not more. I've done a history with people before. And I go, okay, give me the breakdown, right? Breaks, surgeries, hospitalizations, fractures, whatever you got. And I go, wow, they're doing an inventory. Yeah, athlete, ankle, had a high ankle, and then I did my shoulder in 22, and then I did my elbow, and they got it. And like, yeah. And I'm looking at 2 Voldemort scars. Yep. Like right down Main Street, and I'm like, oh yeah,
sorry, tore my ACL.
Yeah, ACL, both one play. I was in traction for like 9 weeks. I'm like, huh? But to the point of that, and thank God our brain operates in this way most of the time. It's like, okay, great.
So we give them these graded exposures to these positions. They're not going to notice it in the gym right away. Right? They're going to notice it when they don't notice it. So you got to bring that back up. Like, hey, you said it hurts in the car upstairs. Oh, you know what? Putting my socks on. Oh, you know what? Funny thing. It's like, dude, that's such a value. Okay, great. Yeah, good. We're making progress. That'll be the first thing that will be the first thing they notice, and it'll be the first thing that goes away. Right.
I'll also play with that topic as well. If I have there's someone that's constantly saying pain, referencing pain, I'm not going to ask them all the time, hey, does that hurt? Hey, how does your knee feel? I'm just going to act like it's not happening. I'm just watching the movement, watching it occur. And then maybe after we do it 2 or 3 times, like you said, hey, how are you doing? How your knee feeling? Oh yeah, I feel great. I didn't even notice it. I didn't even think about it. So that's interesting you say that. So when it comes to identifying pain, and me and you talked about this previously, like let's say as coaches, we love to get really cute with corrective exercises because we want to fix things. We are empowered. Why would we not want to give someone value when they're coming looking for it? So if someone comes in with shoulder pain, it's like, oh, okay, shoulder pain, I'm gonna run there. And one of the biggest things I try to do is just because there's smoke there doesn't mean that's where the fire's at. So it's like, how do you as a coach identify where there's a problem and where I need to keep going back? Because when you reference like that person of they were there before you, like what were they there before you? It's almost like when I experience an injury or a setback with someone, it's like, just because that's where it's at, that doesn't mean that's what caused it. And that doesn't mean where our rehab process should start. So how do you identify that?
Yeah.
Let's go with something like the shoulder.
You heal an injury, you unlearn pain. And I think that's a really good axiom to move through, because your starting point has to be to fit it into the model. It's like, well, how much of this acute sensation or this acute perception is sensory, right? So how much do I need to focus on attenuating load or decreasing load because it is signaling pain, versus how much is this pain a learned experience that I need to unlearn? Because there's like work and load and complexity are inversely correlated. And we go, well, the position and the dynamics of the T-spine and the rib cage will directly impact the position of the scapula. So we go, okay, scapular drills, face pulls, all the way to like landmine presses, to pull-ups. And that's the trick. It's like after a while, when you get good at this, how do all exercises exhibit these movement qualities, right? So we have our remedial T-spine rib cage drills that are maybe on the floor, maybe using a wall. But if I'm doing a cat-cow, when does this become a chest-supported dumbbell row? When does this become a cable pullover, right? So how can I scale the intent of that movement quality up to a point where it's loadable? Because if I take a girl full stack on a pullover, I don't need to revisit this remedial exercise, right? And that's, at the highest level, you provide value by solving more complex problems faster. So if I can come in and be like, I know exactly how to get your name on the phone book, boom, flip right to that exercise. I don't need to waste a lot of time with some of these more remedial drills, drills that I don't like. But when the 6'10", 73-year-old comes in, first page, hey, we're getting on the floor. We're going to cat-cow, because to him, that's a meaningful stimulus. I'm not going to throw out full stack on the pullover and expect him to do that. It's like, no, I know based off of a lot of factors that we're going to have to be here. Or if I take someone off the table, post-op shoulder labor and rehab, we're not going to go into, a single arm alternating incline dumbbell press. Right? It expresses some movement quality. It has some anti-rotation properties to it. There's some movement through the scap, movement through the humerus. It's like, no, we're going to peel. We're going to go to our index and we're going to go right to the top. But it's the ability to fluctuate, right? So we have T-spine rib cage. And there's ways we can divide that through sagittal and frontal. Some are rotation, like the thread the needle. Some are, sagittal, like the cat-cow. So we can get really granular in the way we lump these things together. And we move off to the scapula. There's 2 ways to categorize scapular movements, right? We have upward rotation and downward rotation. A lot of people think of the scap like, and it's not wrong to think of it this way, but protraction, retraction, elevation, and depression. It's like, yeah, they're all parts of upward and downward rotation. It's not like you're a Harry Potter fan? So it's not like the Harry Potter elevators that move like this. That's not how the shoulder blade works. Like there's a bone there. Like you're not going to be able to do that. So I think of serratus drills, and trap drills kind of being the upward rotation, and then things like band pull aparts and face pulls are sort of that downward rotation, resisted downward rotation. And then now I have two sort of buckets. So I have like my T-spine and my ribcage bucket, and I have my scap bucket. T-spine and ribcage has like, well, is it rotation? Is it flexion extension? Is it lateral flexion? I get to the scap, it's like, well, is it upward rotation or downward rotation? Now when we get out to the humerus, the stage has been set. A lot of times when we look at deficiencies in range of motion in the shoulder, we're looking at it through the lens of internal and external rotation. He or she lacks IR or ER. It's like, do they lack it, or do they start in a position that you don't think is efficient? Right? Like the pitcher is the common one. You work with a handful of guys in the MLB, their arc of rotation is amazing. It's just in the other room. We just need to go get it, right? So, the pitcher lacks IR. Like, absolutely no, he doesn't. We just pick an arbitrary starting point of here and go. But what you're missing is he's fucking high-fiving the third base coach before he fucking lets that thing go. So he has a lot of external rotation, but it's all rotation. It's just, where is that arc of rotation set? So now we have drills that we can, like, as basic an internal rotation drill as a cable at 0 degrees of abduction. I can scale that up to a dip, and now I have the most advanced internal rotation drill imaginable. Yep. Ouch, ouch, it hurts to do a dip. Okay, somewhere between here and here, we're on the index of exercises. Let's do a decline dumbbell bridge press. You know, bridge my hips up, here, press. Oh, we're getting a little bit more IR than a flat. Okay, let's go on a decline bench. Let's get a little bit more shoulder extension. Next thing you know, graded exposure. We've trained that movement quality from isolation all the way to integration, right? So then we have, like, let's take external rotation, right? External rotation can start here, but like grab that kettlebell and just give me a bottom under press. Like something like this, right? Now, one thing I want you to do is you come up, press up, have your palm face me. So, right, he's just internally rotated the shoulder. And before he starts, I want him to elbow to the front. Good, so we can stack that wrist over the elbow and bring that down. Good, that's probably one of the more advanced external rotation drills you can do. So as he presses up and he kind of opens that shoulder, and he internally rotates, Terry's minor is gonna then take this humerus as it shortens, and that elbow is gonna come forward. Right?
Turn it forward?
Yeah, so that elbow goes forward.
Yep.
That's your teres setting the humerus and the scapula. You found a little bit more stability. That's a great external rotation exercise. Where you're integrating the function of that teres. Because put your other hand up in the air. Imagine your other hand is doing a pull-up. Same position, palms forward on both. How are you going to start that pull-up? Right, elbows to the front of the room. Yep. Humerus is nice and stable. Scap kind of goes in the back pocket. Now we have a point to extend the shoulder.
Yeah.
Right, so try and bring that elbow out front here and come down, right? So we can, bring it all the way down. Now we have internal and external that exist on this spectrum, right? We have the spectrum of like, well, external rotation with a cable here, probably going to be a starting position for a lot of people, right? If you're a post-op, if you're a novice, sure, this is absolute utility in this when selected for the right population. And here's like the real magic of all this. Minimizing redundancy. Like, I'll never forget, I was in the California Bay Area, kind of at the peak of the CrossFit days. Y's, T's, W's, I's. It's like, you ever see the meme of the water polo goalie in the deep end? Just with like the Dasani bottle?
Yeah.
It's like, when I watch the Y's, T's, W's, I's, it's like, what about the rest of the shoulder? Yeah. We're kind of like, we don't know how to, like, what's called like a factor analysis. We don't know how to differentiate what's different and what's the same about exercise. Like pull aparts and face pulls. Like, look, at the end of the day, they are more similar than they are different, right? We could talk about profiles and cables and ropes versus bands, but if we differentiate it between that and a T-spine rotation drill, it's like, well, this is a scapular exercise, right? We're moving our shoulder blades into this upward and downward, like resisted downward rotation of sorts. It's like, is this meaningfully different to this? Well, if I had to compare what was more different, a face pull or a pull apart versus a pull apart and a thread the needle, I'm going to grab a thread the needle, I'm going to grab a scap drill, I'm going to grab an IR, ER drill, and we're going to cook. The idea of progressive overload leaves a lot of people chasing their tail when it comes to managing pain. Because one of the things that you get into the habit of is, okay, you hurt your knee squatting, we're going to squat light until it doesn't hurt anymore, like we're going to start doing body. It's like, no. We need to play on a different axis, because thinking is a constraint to load, right? I need to give you something else to focus on, right? So I need to come up with an exercise progression schematic that isn't just this one exercise that you've loaded, that you hurt yourself, that we now need to reintroduce. And it's funny because it's such a pervasive thought process in basic remedial physical therapy, right? Because they totally negate the unlearning portion of it, right? And then, but when I introduce new exercises that you have to learn, now we're moving the needle. The focus is on learning the skill, right? And then with this really comes the sound principles that dictate, like, okay, if I need to unlearn pain and I'm outside of any window of tissue damage, like someone comes to me and is like, low back, played JUCO, disc slip, whatever, and he's like very cautious about it. I go, okay, I'm not worried about healing the damn thing. I'm worried about unlearning the damn thing, right? So I have very finite, granular progressions. So if I just take this guy and I go, okay, we're gonna squat the bar, and then we're gonna squat 2.5 pounds. It's like, oh, I know. Let me guess. We're gonna squat 5 pounds, and then 7.5, and then 10. It's like, I need them to have big wins every day to change not only the psychology, but the physiology.
So if I'm being quite honest, you posted on social media a ways back, and you said, stop chasing progressive overload. I'm making this simple. We should be chasing a progressive stimulus.
Right.
And I can't remember which context you use it in, but for me, it was like one of those moments where it was like, when you get thumbs up by people you respect? For me, it's just like, he has no idea, but he just validated every thought that I've been having internally. And for one, it's great to know another coach is along a journey that seems like we're driving along the same road. This is a 2-lane road, and I'm not by myself now,
right,
which is a nice feeling.
Yeah.
And the other one was it empowered me, and it empowered my clients, I think, because I stopped thinking of progressive overload as weights and numbers. Because I think overload, we just think numbers, whether that's weights, speed, whatever it is. It's numbers that were quantitative. Now it gives autonomy to a client because they don't get just stuck where, hey man, I can't squat today. I don't have a barbell. Hey, I can't do leg extensions. I don't have a leg extension machine. Be like, oh, just think about the pattern. Think about the pattern and what can we get out of it? Yeah. And then as me as a coach, it's like now those slight deviations of difference, and sometimes different is all that you need. And a good example I can give is I had a client one time that was having knee problems, knee pain, and whenever we would perform lunge patterns or whatnot, he would experience that. So it was like, okay, how do we get him in something similar? Because I want him to be able to lunge. That's a pretty primitive movement pattern. And I started adding some perturbations, whether it was him holding a band, shaking it, up on him, touching him, moving him. And he felt like it was almost gamified. He's smiling, he's laughing, and I'm like, how's the knee? Man, I'm not even thinking about it. Perfect. Same thing, now we add some movement. Now we add some locomotion, same perturbations. And just that different input allowed him to forget like the focus of thinking about his knee when he was in that pattern. So that progressive stimulus for me, it validated what I was doing. So thank you. But for two, it opened my eyes to like how much bigger I can take this.
Well, because I mean, the difference between progressive overload and overstimulus is what happens at the end tails, right? When we overload, we fail, but when we overstimulate, we err, which means there's a difference between failure and error. And it's about this idea of prediction error. So really what the brain is trying to do when it's trying to learn a movement. And look, motor learning happens whether we know it or not. So we might as well facilitate it. Because whether you want to get out of pain or unlearn pain, whether you want to get bigger, you want to get stronger, faster, jump higher, whatever it is, there's a motor learning component that drives the qualitative adaptation that allows your energy expenditure to be efficient to drive towards whatever goal you're trying to achieve. And your brain, in the learning process, learning is about minimizing prediction error, right? You teach someone you teach a client an exercise, they watch you do it, they're generating a prediction of how they're going to do it, right? Like this is really technical, and we take this for granted, right? Like we take it for granted in large part because we've been physically active our whole life. We have this set of motor skills, we have this awareness of where we are in space. But you take someone who's never trained before, mid-30s, it's like, think about learning a language. Right? Like, I'm in my mid-30s right now. If I Duolingo to, Mandarin, someone could say it and I go to say it right back and I'm like, whoa, like I'm way off because I don't have the phonetics. I don't have, right? Like I don't know how to make the noises of the language. It's like me at 35 is going to have a way harder time with Mandarin than me at 10.
Yep.
Right. And movement trends along similar lines. That's why, like, early specialization in sport is such a bad idea. It's because we create like a rigidity in the way that we learn, because motor learning is happening. And regardless of what we're trying to do. So we got to stop looking at the motor output and think about training. We got to think about the motor learning and think about teaching. When I think about teaching, like, I mean, I wasn't a great student and I would cram for tests all the time, and it didn't work out that well. Right. I did say I went to chiropractic college. Right. So it's like, clearly I wasn't like an A+ student, but and the things that I like to learn, I intuitively know how to learn them. So the way that I learn things, like whether it's more stuff about neuroscience or training or whatever, or like a guitar, like an instrument, in learning these extracurricular skills outside of training and rehab, it taught me so much about learning motor skills in general, because it's the same process. We have a prediction of what's going to happen, and we have raw sensory data that gives us an error signal, and we want to close that gap, and we can close it from both ends. Right? I can give you better data about what the thing's supposed to look like, and you can make a better prediction, and then you can minimize the amount of error. And then you can, as you increase the sensory data, whether it's your foam rolling or these perturbations, it's like, oh, you're introducing this minutia of like, oh, we get to close these gaps. And the brain loves when we close these gaps. We've learned something, we've overcome something, and that starts to feed into this entire model. So predictive error signaling is this idea that, like, okay, error is the key, because error is the prerequisite to learning, right? Like, if I sit and learn guitar, I'm going to make mistakes, but those things signal what I need to fix.
Prescript. Everything you're doing with educating coaches, I mean, anyone that's watching this, I think they understand your breadth of knowledge, experience from every aspects of corporate to high-level D1, professional sports. If you were to offer a piece of advice of where you think coaches should be exploring, or concepts or thoughts, or what's kind of motivating you right now or interesting you or the coaches you work with or train, what is something you would encourage someone to kind of deep dive on?
Work for free.
Mm.
Because that's the deep dive, right? Like, dude, don't go out and learn cognitive theory. Learn it if you want. Learn predictive processing, right? Learn computational neuroscience if you want. But you can be successful in this game without it. But like, look, you're not going to jive with it. Right? Try and read, and like, it's tough for me, and I'm clearly, like, this is my jam. Like, you pick up Vision by David Marr, and you look at like computational neuroscience. Some people are just like, what? I don't want. This is why I got into training. I don't want to learn about the computational layer, the logarithmic layer, the interpretational layer of vision. What does that have to do with anything? It's like, yeah, maybe not anything, man. But go experience. Right? That's how I ended up here, is like, yeah, sure. Sounds good. I'll figure it out. Right? So like, there's so many different ways to get to the end result. Like, you and I, like, we met in Dallas a few years ago at Nate's thing. And I'm like, oh, this is my guy.
Yeah.
I knew you for 5 minutes. Like, this is my guy. We stayed in touch, grab coffee, do this whole thing. And we, like you said, we're just, hey, you've been doing that. Like, you go by it by different names in different populations in different settings. But we look and we're like, oh, yeah, we're doing the same thing, dog. And like, what the thing we're doing is we're getting results. So I don't like to, what shaped this for me was my experience. And I don't want to rob someone of their opportunity to find their experience, because I don't know what it is, man. Like, call it divine intervention, call it, whatever, but get into a room. Get into a room where you're excited to be there. And you know how you'll be excited? Because if they're not paying you, you got to have some other motivation to get up and go. And just provide value, and you'll see where your holes are. And it's like, when the student is ready, the teacher arrives. I have no idea what's going to click for people. No idea. And I could almost guarantee you it's not going to be the inane neuro shit that I get into, right? Because at the end of the day, it's like, I think of my approach like a Richard Mille watch, right? Or a Richard Mille watch. Mm-hmm. There's 1,000 moving pieces under the case. But at the end of the day, oh, look at that. It's fucking 4:30, right? It's like, it has to be that simple. Me and you can sit, we can riff, we can talk to coaches, and it can be fun. But it's like, what did we say, right? Like, I said 10,000 words. I did a PhD dissertation on cognitive theory. And I said, yeah, like, if people like foam rolling, you should probably do it. Yeah. That's pretty dope. So go figure out what that vector is for you, right? Like, and I think if you're looking for it, you'll never find it. You have to go experience it. Right? Because like we talked about, like, that's what's going to shape the learning process. So I don't want to be prophetic and be like, man, the next wave is going to be, we really got to bring back the pogo stick.
Yeah.
Right? The pogo's going to be it, dog. We got to bring back moon shoes like Seinfeld. It's like, I don't know, just go to a setting and be like, hey, do you guys need some help? Be of service, provide some value, make a shit ton of mistakes, and something will be like, I'm going to look into that. He said something cool, I'm going to do that. But like, yeah, I don't go experience and you'll figure it out.
That was a perfect answer, dude. Yeah, I'm gonna be honest. I haven't figured out an exit strategy of any of these podcasts yet.
Yeah.
So how do you exit yours?
Wrap.
It's a wrap.